All right, so we just heard two great talks on how we optimize and position our current therapies. And for the next talk, again, my name is Dr. David Hudisman. I'm co-director of the Inflammatory Bowel Disease Center and associate professor of medicine at NYU. And I'll be speaking about some newer and emerging therapeutic targets. So the therapies we've just been hearing about, unfortunately, there are limitations of these therapies. You know, it's great that we have so many options now, from anti-TNFs to anti-integrins to anti-IL-23s and JAK inhibitors. But unfortunately, right, they're not going to work for all of our patients, and a lot of our patients could lose response. So just some of our current limitations is, number one, primary non-response. Whether you look at clinical trial data or real world data, anywhere from 20 to 40% of patients will not respond to the therapy we put them on. And whether that has to do with the severity of disease when we start that therapy, or we're just picking the wrong mechanism of action. Secondary loss of response, which we also heard about a little bit earlier, occurs in up to a third of our patients, if not more, by the end of the year, in both our biologics and JAK inhibitors. And a lot of times this is secondary to immunogenicity, but we do have many patients that are on a biologic that initially did well, that still has a therapeutic drug level, but they lose response. And possibly this is a shift to a different inflammatory and molecular pathway. We always have to be concerned about adverse events and safety. And another major limitation, route of administration is important to think about, especially compliance with our patients, whether they're taking something orally daily or an injection or infusion every 8 weeks. And then cost is insurance is a big burden to both patients and providers. So it's a pretty exciting time right now. There's many therapies in the IBD pipeline, and this is just some of them that I've listed here. And I'm going to touch on the ones that I bolded. But you know, a handful of these therapies we're hoping are going to be FDA approved for either or both Crohn's disease and ulcerative colitis, starting within the coming year and out to the next few years. I'm going to touch on selective IL-23 inhibitors. We heard about JAK inhibitors earlier on. We're going to touch base on selective JAK inhibitors on this talk. And then I'm going to touch on anti-trafficking agents, both anti-adhesion therapies and Sphingosine 1-phosphate receptor modulators. So the first class of medication I'm going to talk about is along the IL-23 pathway. And ustekinumab is our biologic that blocks the P40 subunit, which you can see here in both IL-12 and 23, and it's approved for both Crohn's and ulcerative colitis. IL-12 leads to development and mediation of the Th1 response, and IL-23 leads to stabilization of Th17 cells. And in a normal state, IL-23 and Th17 is important for our regulation of response to our microbes. It could possibly build up our barrier defense and possibly downregulates inflammation. And the thought is that if we selectively block IL-23, this is something that could be more targeted towards the mucosa, towards the intestine, and possibly have better safety and better efficacy. And this is something we're going to need to see from our IBD literature. But if you look at the psoriasis literature, the selective IL-23 inhibitors do seem to do better than ustekinumab. So the way these selective IL-23 inhibitors work is they're blocking the P19 subunit. Again, that's only on IL-23, not IL-12. So the first study I'm going to talk about, and most of the data I'm going to present here are all recent posters or abstracts or publications within the past 2 years. So the first study is a phase 2 trial that was published this past year in Gastro with mirikizumab. And this is an antibody to the P19 subunit of IL-23. And this was studied in moderate to severe ulcerative colitis. And the way these trials were done was in the phase 2 trials, these are dose-finding trials. So you'll get a few different dosages of study drug versus placebo. And these patients received an IV dose at week 0, week 4, and week 8, and looked at a week 12 endpoint of remission, which takes into account both endoscopic appearance as well as rectal bleeding and stool frequency. And the maintenance phase, patients were randomized to a SubQ arm. And you could see here that in this phase 2 trial, if you look at the endpoints of clinical remission, clinical response, and endoscopic improvement at week 12, that the mirikizumab did better than placebo. And there does seem to be a some sort of dose response curve, meaning the higher the dose, the better the response that then seems to plateau, which is what we'd like to see in these phase 2 trials. Risankizumab is another selective IL-23 inhibitor, and I'm going to show some of the data that was presented at DDW in 2019, looking at risankizumab for moderate to severe Crohn's disease. Similar study design to the mirikizumab, where patients received a couple different IV doses versus placebo at week 0, week 4, and week 8, and looking at the endpoint of clinical remission at week 12. And just like for the mirikizumab, patients are re-randomized and go onto an open label SubQ maintenance arm. So here, if you look at the endpoints, both clinical remission, and if you look at endoscopic endpoints of endoscopic response, endoscopic remission, and deep remission, that again, we saw statistically significant benefit with risankizumab over placebo, and again, that nice dose response curve. So the mirikizumab, that's moving towards phase 3 trials and enrolling for both Crohn's and ulcerative colitis. And risankizumab, I think, just completed enrollment or about to complete enrollment for Crohn's disease. So that's pretty exciting, and hopefully we'll have some data from their phase 3 trials in the next year or so. Now, what about safety of these agents? So as I mentioned, ustekinumab was FDA approved for both Crohn's and ulcerative colitis in the past few years. However, it's been on the market for psoriasis since 2009. And they have a safety registry called the SOLAR registry. And they were looking at patients that were on ustekinumab and other biologics or non-biologic agents to treat psoriasis and psoriatic arthritis and looking at adverse events. And what they saw was that ustekinumab did not increase the risk of serious infection, malignancy, this excluded non-melanoma skin cancers, major adverse cardiac events, or all-cause mortality. If you look, though, at anti-TNFs in this registry, they did increase the risk of serious infection. Now, taking a look at the safety data that we have in the short term from our IBD patients in the clinical trials, as well as our real-world experience, that ustekinumab seems to be a safe biologic agent. So moving on to some small molecules. So just some basics before we dive in. So just differences between small molecules and biologics, despite the fact that the small molecules are small. First, small molecules are simple, well-defined structures compared to biologics, which are more complex. Small molecules are typically oral, whereas our biologics are IV or subcutaneous. And very importantly, small molecules are non-immunogenic, meaning that we don't have to worry about antibody development and reactions like we do with our biologic agents. So the next class of drug I'm going to speak about is JAK inhibitors, and we heard a nice talk just previously from Dr. Herpes. And JAK-STAT signaling is really intracellular signaling that leads to downstream gene transcription, and it's involved with development and maturation of our immune cells, of our growth factors, and a variety of different cytokines could affect this JAK-STAT signaling. This is a nice graphic looking at this in a little more detail. So there's 4 JAK proteins, JAK1, 2, 3, and TYK2. And these are just a few cytokines that mediate inflammation through this JAK-STAT pathway. There's a lot more. And just for example, if we have a drug or a medication that blocks JAK2, right, this should downregulate EPO. Therefore, not something we want to give to our IBD patients since it would make them anemic, but possibly a good treatment option for somebody with polycythemia vera. So first, to talk about safety. So tofacitinib has been on the market now for moderate to severe ulcerative colitis for a couple of years, and a couple of safety signals have come up that I want to touch on before we talk about the more selective ones. So first is Herpes Zoster. So if you look at the entire clinical trials programs for tofa and UC, there were 1,157 patients. 5.6% of them developed herpes zoster with an incidence risk of over 4. The median time to developing herpes zoster was 325 days. And this side effect was dose dependent, meaning that 10 milligram twice a day dosing had higher rates of zoster than 5 milligram twice a day. Now, though, we have the Shingrix vaccine, which is an inactivated zoster vaccine, which really minimizes our risk for zoster for our patients, as long as we could get them vaccinated. The other safety signal I wanted to touch on was this increased risk of pulmonary embolism and all-cause mortality that was seen. And this was seen in a phase 4 follow-up safety study in the rheumatoid arthritis patients. So patients with RA over the age of 50 with at least one cardiac risk factor were at increased risk for both PE and all-cause mortality. So because of that, if when using tofacitinib, we want to risk stratify our patients, we want to make sure they're not high risk for developing clots. The FDA made a statement that tofacitinib should be used second line after anti-TNF, and also recommended limiting the use of the higher dose, 10 milligrams twice a day, where that signal was shown, to the shortest duration as we think is needed. Now, the real question is for our newer, more selective agents I'm about to talk about is what the FDA is going to say about them. And really in our IBD patients for tofacitinib and the early clinical trial data for our more selective JAK inhibitors, we have not seen this increased risk of PE and all-cause mortality. And whether that's disease state, there's some other theories, or just we don't have enough long-term follow-up. So the first selective JAK inhibitor I'm going to talk about is Eupatacidanib. This is a selective JAK1 inhibitor. This was presented at DDW back in 2019. And again, similar to what I showed with IL23 inhibitors with the phase 2 studies, different oral dosing versus placebo. And you could see here higher clinical remission rates in patients at week 8, which was at their primary endpoint, and a nice dose response curve. We also saw a nice endoscopic improvement with Eupatacidanib in ulcerative colitis at week 8 as well. Their phase 2 data in Crohn's disease, or the Celeste trial, was published this year in Gastro. Endpoint here is clinical remission. And again, you could see that there's a dose response curve and patients did well with Eupatacidanib in Crohn's as well, with statistical significance over placebo in some dosing groups. So this is, probably some of the most recent data I have for you. This is probably less than a month old. The selection study was filgotinib in moderate to severe ulcerative colitis. Filgotinib is a selective JAK1 inhibitor. And they looked at, looking at their phase 2b/3 induction trials. There were 2 of them, and then their phase 3 maintenance trial. And they just put out this data. And what you can see here, in the moderate to severe UC, the primary endpoint, which was clinical remission, taking into account both endoscopic scores as well as rectal bleeding and stool frequency, was higher with filgotinib over placebo at week 10. And this was both in biologic naive patients and biologic experienced patients. If you look at their 1-year maintenance or their week 58 maintenance data, again, you see statistical significance. So it's great to see this phase 3 data in filgotinib, and hopefully we're going to have a more selective JAK inhibitor for UC hit the market within the next year. So moving to our last class of agents, our anti-trafficking agents. So the first agent I'm going to talk about are these Sphingosine 1 phosphate receptor modulators. So this is a little bit different than Vitalism or Antiintegrins. And our anti-integrins prevent the white blood cell from getting to the intestine or binding to the endothelial cell to get into the intestine. The way these medications work are lymphocytes leave the lymph node through the Sphingosine 1 phosphate receptors. So ozanimod and Trezomod, 2 of the medications I'm going to be speaking about, down-regulates or down-modulates these receptors, keeping these lymphocytes within the lymph node. So almost a step up from where our anti-integrins work. This was their phase 2 data published a few years ago, looking at 2 different doses of ozanimod versus placebo. Their primary endpoint at week 8, looking at clinical remission, clinical response, and mucosal healing. And they also hit their week 32 endpoints. There was an announcement or a press release in early June that their phase 3 data for ozanimod and ulcerative colitis hit their endpoints at both induction and 1-year maintenance. That data has not been released, should be presented at upcoming conferences, and hopefully we're going to have a second oral small molecule approved within the year for ulcerative colitis. This is just some secondary endpoint analysis from a Trezomod presented at last year's DDW, just looking how this Sphingosine 1 phosphate receptor modulator had higher rates of both endoscopic improvement and histologic improvement and histologic remission. So that these medications have not only shown benefit clinically, but endoscopically as well. So what about safety concerns? So there's a non-selective sphingosine 1 phosphate receptor modulator called fingolimod that's on the market right now for MS. And with that, there's been some safety concerns that have come out. Some have been serious infections, herpes zoster, as well as PML, which we've seen with natalizumab, our non-selective anti-integrin. Also, we've seen bradyarrhythmias and AV conduction delays with fingolimod, as well as macular edema. So patients in the ozanimod and the Trezomod clinical trial programs needed to get frequent EKGs, as well as opto visits. Now, both ozanimod and Trezomod are more selective, so hopefully we won't see as high of a rate of side effects of these specific side effects. However, we're going to need to see the clinical data, and it's going to be interesting to see what the FDA recommends for these patients when hopefully ozanimod hits the market soon. So the last class of drug I'm going to talk about are the anti-integrin. So everybody's familiar with Vitalisumab, and I just wanted to present this study. This is a SubQ formulation of Vitalisumab called the Visible study. And the way this trial was designed for ulcerative colitis was that all patients got your typical IV Vito, 300 milligrams at week 0 and week 2, and then were randomized to either SubQ Vito every other week or IV Vito every 8 weeks. And you could see here that the primary endpoint of clinical remission and secondary endpoints of endoscopic improvement at week 52 were statistically higher in the SubQ Vitalisumab over placebo. You could see here that the numbers look similar between SubQ and IV, but this study was not powered to look for a difference between SubQ and IV. So because of that, the FDA is still asking for some more clinical data before they will approve SubQ Vitalisumab. But hopefully, if the data looks good, we'll have an option that's more convenient for our patients. And then the last drug I'm going to talk about is Eternalism. And this was a recent press release, actually this past week, I believe. And Eternalism is an alpha-4 beta-7 anti-alpha-4 beta-7 and also anti-alpha-E beta-7 integrin. So similar mechanism to Vitalisumab. They had a very ambitious clinical trials program. I believe at least 7 clinical trials with this drug going on at once. And you could see here that unfortunately, the results, or at least the press release, say that the results weren't as expected. So there were mixed results in the induction studies, where one study met the primary endpoint, one study did not. And really, in looking at all their maintenance data, they didn't hit their primary endpoints. So that is, a little disappointing. We need to see the full data, but again, mixed results with Eternalisumab in moderate to severe UC from what we know to date. So just to summarize, we touched on a variety of different agents, and again, it's a pretty exciting time. We touched on selective IL23 inhibitors, JAK inhibitors, more selective JAK inhibitors, and then anti-trafficking agents, both the Sphingosine 1 phosphate receptor modulators and our anti-integrins. However, with more therapeutic options, there are more questions. And these are the things we're starting to talk about now, but what we're going to continue to talk about over the next few years. So we just heard some great talks on positioning of IBD therapies, and really, how do we decide what comes first? What's the best way to set this up, to set up the patient for success, not only in the short term, but for long term? It would be great if we had early predictors of response or biomarkers. So if we start somebody on an agent, within a short amount of time, we know, should we continue or should we pivot to something else? There's some early data, for example, looking at IL-22 levels as a predictor of response to selective IL-23 inhibitors. Really, the ultimate goal is, can we personalize therapy? Can we ahead of time pick the right drug for the right patient? And there's a lot of translational work being done on this, but we're not quite there just yet. And then really every drug I've spoken about and sort of the other drugs that are coming to market, although it's great to have them, they're going to give us more options for our patients. Not any of these drugs are going to be significantly more efficacious than any of our current drugs. And what I mean by this, these response and remission rates with these newer therapies aren't going to be 20, 30% better than what we're seeing now. So how do we get there? Maybe we're going to start talking about combining therapies with different mechanisms of action. And there's been some recent data on this. So thanks for listening and looking forward to the discussion.